Hello everyone, my name is Keegan Frenya, and today we will be exploring the large intestine. As for myself, as you can see here, I have a happy little family and a wonderful son that is almost 10 months old. As for my future endeavors, God willing, they will include me entering dental school after completion of the Master's of Arts in Medical Science program. As we are told in Scripture, God created man in his own image. In the image of God, he created him, male and female. Genesis 1:27. The Bible contains an abundance of evidence of the innate value in man as he is created in the image of God, esteemed far higher than any other aspect of creation. Jesus frequently met the physical needs of people to subsequently heal them spiritually and physically. People would become intelligent and caring doctors, but the love of Christ far surpasses the love of man. Through Jesus, we can display divine love towards others, which will lead to profound effects on the medical field. The large intestine involves the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, the rectum, as well as the anus. The colon absorbs vitamins which are created by colic bacteria such as vitamin K, vitamin B12, thiamine, and riboflavin. It also compacts feces and stores fecal matter in the rectum until it can be discharged via the anus in the process of defecation. The large intestine also secretes vitamin K, and chloride. Recycling of various nutrients takes place in the colon as well. For example, fermentation of carbohydrates, short-chain fatty acids, and urea cycling. The large intestine can easily be distinguished from the small intestine by tinea coli, which are three thickened bands of longitudinal muscle. The saculations on the wall of the colon between the tinea coli are called haustra. Epiploic appendices or omental appendages are small pouches of omentum filled with fat, which, as you can see in the picture on the right, are the yellow protrusions from the large intestine. The large intestine begins at the cecum, which is in the location of the right groin, as seen on the right. The cecum is a pouch in the iliac fossa, and it is roughly 5 to 7 centimeters. The cecum is continuous with the ascending colon as observed in the right flank. Unlike the ascending colon, above it, the cecum is intraperitoneal. As stated previously, the first aspect of the large intestine is the cecum. The ileum itself, which is the most distal part of the small intestine, enters the cecum obliquely and partly invaginates it, forming lips superior and inferior to the ileocecal orifice. These lips of the ileocecal valve meet medially and laterally to form ridges, called the frenula, of the ileocecal valve. The circular muscle itself is poorly developed, and the ileocecal valve has little sphincter action. The physiological function of the cecum is to remove water and other key nutrients from waste material and recycle it back into the body. A structure found on the cecum is the appendix. It can be variable in length and roughly 8 centimeters long. The appendix has its own short triangular mesentery called the mesoappendix. The position of the appendix is variable on the cecum. It can be retrocolic, which occurs in 65% of people. It can be in the pelvic direction, which occurs in 31% of people. Or it can be subcecal, which is roughly seen in 2.3% of the population, and rarely it is either anterior or posterior to the terminal ileum. The physiological function of the appendix remains largely unknown, and it is thought that it is associated with holding bacteria. The next structure that we will be exploring is the ascending colon, which is distally to the cecum. It is on the posterior surface of the iliacus, quadratus lumborum, and transversus abdominis. Anteriorly, it is related to the colus of the small intestine and right edge of the greater omentum. It is associated with the right colic flexure, which merges into the transverse colon. The physiological function of the ascending colon is to absorb remaining water and other key nutrients from indigestible material, solidifying it to form stool. The next structure that we will be looking at is the transverse colon, which is the largest structure in the colon at roughly 50 centimeters. It stretches from the right colic flexure to the left colic flexure. The physiological function is similar to that of the ascending colon, which is absorbing water and other key nutrients such as electrolytes and solidifying substances into stool. 95% of the water that is absorbed in this region is by osmosis. The next structure we have that is distally to the transverse colon is the descending colon, which is roughly 25 centimeters long. It is covered in peritoneum as well. It goes from the left colic flexure to the very front of the left external iliac artery in the level of the pelvic brim, where it becomes continuous with the pelvic colon or sigmoid colon. The peritoneum fixes it to the left pericolic gutter and iliac fossa. The physiological role includes storing feces that will be emptied into the rectum. The next structure is the sigmoid colon, which is distal to the descending colon. It is roughly 37 centimeters long. It is in the pelvis, located in front of the bladder and uterus, and just below the loops of the ileum. The sigmoid colon is suspended from the pelvic wall by a large peritoneal fold, called the sigmoid mesocolon. The sigmoid mesocolon has an inverted V-shaped connection. The physiological function of the sigmoid colon is to store fecal matter. The last structure is the rectum, that is associated with the anus and the anal canal. The origin of the rectum is at the third sacral vertebra. It is straight in nature and has a muscular tunic of smooth muscle that is relatively thick in the rectum compared with the rest of the large intestine. The physiological function is to pass stool that is solidified from the rectum to the anus, and then it is released. Now we are going to explore pathology associated with the large intestine. There is colorectal cancer, which is one of the most pervasive cancer types in the Western world. It is predominantly seen within patients that are above the age of 50 and are non-vegetarians. This cancer involves cells that form on the lining of the colon or rectum. Many colorectal cancers start from growths called polyps, although not all polyps develop into cancer. Various forms of these polyps can be seen in the image on the right. In advanced cases, it spreads to the liver via the portal vein. It's important to follow your doctor's recommendations for colorectal screening as an essential preventative measure. Another ailment associated with the large intestine is appendicitis, which occurs in the appendix. Appendicitis is an acute inflammation of the appendix and the most common cause of acute abdominal pain. If the appendix is not removed, it can become necrotic and rupture, resulting in peritonitis. It is usually associated with the calcified fecal deposit in the appendix. Each year, there are nearly 250,000 patients that suffer from appendicitis. Another possible outcome in the large intestine is intussuspension. It is a clinical condition where a proximal section of the bowel invaginates into the lumen of an adjoining distal section. This may cut off blood supply to the bowel and cause gangrene. The different forms of intussuspension are ileo-ileo, ileocecal, or colic-colic. The ileocecal intussuspension is the most typical form.